Welcome back to yet another topic in periodontics. And today we are going to discuss about advanced diagnostic techniques. Now, when you look at current diagnosis of periodontal disease, now as an undergraduate student, you will be coming to the perio department, and then you'll be trained to diagnose periodontal disease. And basically, you'll be looking at certain aspects clinically to determine whether there is loss of attachment. And to correlate that, you can take a radiograph. So basically, you use a periodontal probe. You visually examine, and then you take a radiograph. The radiograph is an adjunct for your clinical diagnosis. So, but basically, all these current diagnostic methods identifies something that has happened before. Okay. Now, periodontal destruction has taken place, recession has occurred, loss of attachment has occurred, bone loss has occurred. That can be measured or that can be assessed by these clinical methods by means of either probing or by means of radiograph. But the limitation of this is you really don't know whether the disease, there is ongoing destruction taking place, or the disease has stopped, there is a remission there. Certain sites are active or they are inactive, whether the disease is progressing. And suppose you're doing any treatment, whether that treatment is successful or not. So by your current diagnostic methods, you can't identify any of these. You can't identify an active site. If you see that the disease is progressing there or the disease is active in a particular location, you can intervene. But by just probing, you can't know that the disease is active or inactive there. By taking a radiograph, you came to a diagnosis that bone loss has occurred. But is the bone loss progressing there? Suppose you take a radiograph after 3 or 6 months, will you see more bone loss? Or is it in a healing state? All these cannot be evaluated by means of the current diagnostic methods. And hence, we need newer advanced diagnostic aids to diagnose periodontal disease so that you can assess the disease or identify the disease at a very early stage and then take corrective measures. So this chapter is basically where we are going to discuss about the advances in periodontal diagnosis. And when you look at this advances in periodontal diagnosis, you can classify these advances into four headings. One is advances in clinical diagnosis. Second is advances in radiographic assessment. Third is advances in microbiological assessment. And finally, advances in characterizing the host response. In this session, basically, what we are going to discuss is the first two, that is advances in clinical diagnosis and advances in radiographic assessment. The other two we'll be discussing as a separate session. So first we'll discuss about advances in clinical diagnosis. Now clinically, you can diagnose periodontal disease by looking at inflammation. How do you assess the inflammation of the gingiva or the periodontal tissues? That is mainly by means of bleeding. Or you have an advanced technique by which you can measure the temperature of the gingival sulcus and then come to a conclusion that the disease is active or inactive. Second is gingival temperature. And third is the gold standard method by which you diagnose periodontal disease, that is by means of use of different types of periodontal probes. So first, we are going to discuss about gingival bleeding. Now, whenever there is inflammation of the gingiva, there is the color of the gingiva changes. At the same time, if you stimulate the gingiva, there is bleeding from the gingiva. But the problem with the change in color is it is subjective. Now, when we take a case history, and suppose I am examining the patient, I'll look at the gingiva in relation to that particular tooth, and then I'll be recording as bluish red. A second person will be examining the same area and they'll be writing as grayish red. So there is that subjective difference in the evaluation when you look at color changes. But when you look at bleeding, now if I probe in a correct manner and there is bleeding and probing, if another person probes also similarly, there will be bleeding and probing. That is more of an objective evaluation. So you don't take the color changes to evaluate the inflammation of the gingiva. You look for bleeding. Now, bleeding is a very good indicator of the underlying connective tissue destruction. And the severity of bleeding increases with the increase in size of the inflammatory exudate. So as the inflammation, the degree of inflammation, intensity of inflammation increases, the degree of bleeding, the intensity of bleeding, or the more the bleeding from the gingiva occurs. Now, how do you usually check for gingival bleeding? If you insert a probe too hard into the gingival sulcus, definitely, even if it is a healthy gingiva, the gingiva will bleed. You have to use a correct technique, and the correct technique is running the probe. Usually, you take one quadrant of section. Mostly, you take a quadrant. Okay, suppose you're starting from the midline. Okay, you just insert the probe slightly into the gingival sulcus. Don't exert too much pressure, and just slowly move it around. Slowly move it around the sulcus like this. Just move it around the sulcus like that. Just move it around, all around this area. Go to the most distal aspect, then come to the palatal aspect also. Come to the center point where we start. Then wait for 30 seconds, and then you observe whether bleeding is there. And then with the different indices that have been developed to assess gingival inflammation, you can score this bleeding and then come to a diagnosis in the same in the manner in which what degree of inflammation is there in the gingival tissues. So it is an indicator of disease activity, and whether all sites that bleed are cases of active periodontal sites, it is not unclear. And sites which does not bleed, you can be sure that there is some sort of periodontal stability in there. But this is not true in the case of smokers. Smokers, even in case of advanced periodontal problem, sometimes the gingiva may not bleed because of the effect of nicotine causes vasoconstriction, and the clinical signs are masked there, and the bleeding is also reduced there. Now, what are the limitations when you look at gingival bleeding? Now, one of the most main problem is, as I told you before, healthy sites, especially if you increase the probing force, it can bleed. So healthy sites may also bleed. That's one problem. And any force of more than 0.25 Newton can induce bleeding in a healthy site. So that is another limitation associated with gingival bleeding. So investigators were looking at other means by which you can gauge this inflammation within the gingiva. And another thing they came upon was to evaluate or measure the temperature within the gingival sulcus. Now, you all know that whenever there is gingival inflammation or whenever there is inflammation, there are different cardinal signs of inflammation like calor, tumor, rubor, dolor, function, is loss of function. So calor is increasing the temperature. So whenever there's an inflammation, the sides, the area where there is inflammation, temperature increases. So basically, this has been applied here. Now, you use a particular device by which you can detect the temperature within the gingival sulcus. And if you find that the temperature within the gingival sulcus is more than the normal, then you can be sure that there is some sort of inflammation there. So these sites are more prone for disease activity. So you can identify these active sites and probably you can do some intervention there. So that is a basic idea of measuring subgingival temperature. Okay, and a specific probe has been developed to detect this temperature, and it's known as a Perio Temp probe, which has got a sensitivity of 0.1 degree centigrade. So with this probe, you are actually measuring the temperature within the gingival sulcus, and when you compare it in the normal temperature, you can be sure that some sort of inflammatory activity is going on. So that is a rationale based on which this probe is being used in the diagnosis of periodontal disease. Now this is a Perio Temp. This is a handpiece which goes into the gingival sulcus, and then this is the instrument that actually the machine is connected to a printer that gives a digital readout of the temperature in relation to the different regions in the oral cavity. Now, when you look at evaluation of gingival temperatures, you should know these points. As I told you before, temperature at disease sites or inflamed sites is more than healthy sites. You should also know that temperature between individuals vary. And even within an individual, the posterior sides are more warmer than the anterior sides, and the mandibular sides are warmer than the maxillary sides. So these has to be taken into consideration when you evaluate temperature. So one thing is temperature in the disease sites is always more than that of the healthy sites. In different individuals, the temperature varies. The posterior sides are warmer, mandibular sides are warmer than the maxillary sides. And there are a lot of studies which are available in the literature which says that whenever there is increase in temperature, it is related to attachment loss. And it is also noted that, whenever in sites where there is increased temperature, the periodontal pathogens, the main pathogens which can cause periodontal disease, actually the number is also more, like the number of Provetella intermedia, Streptococcus micros, P. gingivalis, and A. contents. But the exact association is unclear, but there are a lot of studies which give evidence that whenever temperature is increased, there is attachment loss. Whenever temperature is increased in all those sites, the number of periodontal pathogens also increase in number. So we were discussing about the advances in clinical diagnosis, and we first discussed gingival bleeding, and then we discussed gingival temperature, and now we are coming to the last one, that is probing. And this is considered as a gold standard in measuring periodontal disease. Attachment loss. It is the most widely used diagnostic tool, and it is considered as a gold standard for the measurement of attachment loss. But the problem is, it presents many a problem in sensitivity and reproducibility. The problem is, you probe, and I do a probing in a patient, and I take a measurement as probably 5 millimeter in relation to a meson aspect of central incisor. Another person probes and he finds that it is only 3 millimeter. So that is disparity. I probe now, and probably after about someone asked me to probe once more, and when I probe, the probing depth is 4 millimeters. So I can't reproduce the measurement that which I got earlier. So there are problems in sensitivity and reproducibility. So you need better probes. You need advanced probing systems. And what are the reasons for these disparities in probing? Is one is the tissue. Now, when you look at more of fibrotic tissue, the probe won't pass easily in a fibrotic gingiva. But if it is soft in edematic, it's usually so you don't have to use the same amount of force in an inflamed gingiva compared to that of a fibrotic gingiva. So that is another thing. Then inflammation, the degree of inflammation, the smoking, as I told you before, smoking will conceal the clinical signs, even though there is advanced disease. Right? So the main reasons for the disparity is one is probing technique. You should ideally probe parallel to the long axis of the tooth, and you do probing by means of something called as walking the probe. Now, when we discussed gingival bleeding, I told running the probe. So you just pass it to the gingival surface and go all around. Now, here the probing technique is walking the probe. Now, in relation to a single tooth, in different aspects, you may have different amount of bone loss. Now, suppose you're taking a mandibular molar in relation to the fourth quadrant, mandibular 4-6. Now you probe easily in relation to 4-6, and you get a measurement of probing depth of probably about 7 millimeter. Now, in relation to the mid-buccal area, when you measure, probably it will be 3 millimeter. When you measure in the distal aspect, it may be 4 millimeter. Okay. So in relation to a single tooth itself, there is different pocket depths. So that is why you have to do something called as walking the probe. So in relation to, suppose you're probing one quadrant, you start with one aspect, maybe probably you start with the central aspect, mesiobuccal. Then you go, take it out completely, move, then you do mid-buccal. From there you take it out completely, then you move distal. This is known as walking. You are walking the probe. You just don't insert and then try to move it from that area. So take it out, and then that is known as walking the probe. Another problem, disparity in probing that may occur is the probing force. I probably, when I'm experienced, due to my experience, I probe with a lighter force, while probably a third-year student, just as he enters clinic, he'll be using too much force, probably injuring the gingiva. Because the probing force, probe can penetrate more, and the values, the readings may be different. The size of the probe is very important. Now you have probes that probably will get about 10 or 20 rupees, and you'll have probes that is available for about 100, 125 rupees. And you have a similar probe that is available for probably 1,500 rupees. So it is not only the quality or the material of the probe that matters, even the size. Actually, every probe has got a particular. It has to be made in a particular size. So you get a probe from a very good company, like a Hugh Freddy probe, which costs, as I said, because probably 1,500 or 2,000. Now there, the probe, the calibration of the probe will be correct. If it is 0.1 millimeter or 1 millimeter sections, that will be correct. The diameter of the probe will be correct. The length of the probe, the weight of the probe should be correct. So all this is good. Now, if you buy a 10 rupee probe, it will look like a probe, but all these are wrong, and your measurements can go wrong. Then angle of insertion of probe. You can insert in different angle, but ideally the angle of insertion is going to be along the lying axis. And if you probe in a different direction, probably you will get a different probing depth in relation to that particular area. And again, precision in probe calibration. Probes may be calibrated as probably 0.1 millimeter sections, 2 millimeter sections. Then there'll be markings, color codings. So if all these are wrong, if this is not properly, then it is going to be probing disparity. So now this is what I noticed. This area, ideally you should probe like this. But here, if you probe like this, what is the measurement? It's hardly gone into the gingival surface. This is the measurement here. So likewise, you have to, which is if you take a restoration here, you have to consider that restoration, and then you have to insert the probe. Otherwise, you will not be able to measure the actual. And the pocket is here. Now we have gone only till here. We have not got a correct measurement. So which is an ideal probe? Now there is an institute which is known as NIDCR, that is the National Institute of Dental and Craniofacial Research in the US, and they have put forward certain criteria that an ideal periodontal probe should have. But to date, let me say, to date, there is no probe which satisfies all the criteria that has been put forward by the NIDCR. So you don't have an ideal probe, say, now, as of now. But let's discuss what are the properties that an ideal probe should have or should satisfy. Now, when you look at we have the conventional probes that we use now, and then we'll look at the NIDCR criteria. Now, the first is precision. Precision is, the conventional probes, most of these probes have markings of 1 millimeter each. But what NIDCR says is that they should have a precision of 0.1 millimeter. The range conventional probes have 12. NIDCR say that at least 10 millimeter. Probing force. With your conventional force, whatever force the person uses, the person who's probing, whatever force he generates, that is a force. So it's not standardized. While according to NIDCR, the force should be constant and standardized. The fourth criteria is regarding applicability. Now, according to conventional, the conventional probes are non-invasive and they're very easy to use. But the criteria, NIDCR is saying it should be non-invasive, it should be lightweight and easy to use. Then is regarding the accessibility or reach. Conventional probes are easy to access. They can access any location around all teeth. Now, according to NIDCR also, this criteria is more than enough. Then there are some other criteria also. One is angulation. Now, the angulation is you are supposed to probe in such a way that the probe goes along the long axis of the tooth, parallel to the long axis. So it is basically subjective. It depends upon the examiner or the person who is probing it. But according to an ideal periodontal probe put forward by NIDCR, this probe or the probe system should have a guidance to ensure that there is proper probe angulation. So because of this guidance, probably you are probing now and probably you are probing at later period, so probably about 2 or 3 days. Because of this guidance system, you will probe exactly through that particular angle in which you have probed before. So this will be very useful in comparing pre and post probing depths, especially when you are doing periodontal treatments and all. Then the next is regarding the security of the probe. That it can be easily sterilized, and a simple stainless steel instrument. Most of the conventional probes that is the WHO probe or the Williams Benall probe. All these are simple stainless steel instruments. These can be easily sterilized also. And according to NIDCR criteria, any part of the probe that enters the oral cavity, it should be sterilized. All the portions of the probe should be completely sterilized. And there should not be any biohazard or electrical shock. Most of these, advanced probe systems are connected to the electric current. They have, that we'll discuss later. And so there should not be electrical biohazard from this, okay? And usually, how do you evaluate the probing depths? When you take a case history, you examine the, you probe, and then you read out what is the measurement, tell, or suppose 5, and next person, your assistant, someone there will record on the case history. So that is voice, dictation, and recording and writing. But here, according to NIDCR, an ideal probe should automatically detect the probing depth or probably the semi-dynamic junction of whatever it is, clinical attachment level. And then it should automatically, you will get that value in the computer, which you can take a print out. So much advanced the probe should be. So there are a lot of probes that have been available in the market. Different generations of probes are available, but there is not one single probe that follows all the criteria that is put forward by the NIDCR so far. So let's look at the classification of probe. There are 5 generations of probes. Okay. The first generation probe is known as the manual probe. Manual probe is the probe that we commonly use. The Williams Benall probe, the Goldman Fox, the Glickman, Michigano, WHO probe, Neighbors. All these are the manual probes. So these are simple stainless steel instruments. Insert in the periodontal pocket. You have to look, and then you have to measure the pocket, and someone else has to write for this, all the values. So that is the first generation probes. The problem is, the pressure is not controlled here. The angulation is not controlled here. Right? Now, to control the pressure inserted in the gingival sulcus, there came a second generation of probe, which is known as the pressure sensitive probe, by which you can actually control the pressure. You can control the pressure within the periodontal pocket. So here you have control force application. And when you have a force, probing force of within 30 grams, it stays within the junctional epithelium. And if you apply a force of approximately 50 grams, it may pierce the epithelium and the connective tissue and will reach the bone. So to diagnose osseous defects, you probably need a more probing force. Example of the second generation periodontal probes are, or the pressure sensitive probe is the Wine Valley probe and the Vivacare TPS probe. TPS means true pressure sensitive. So these are the different second generation periodontal probes. So here, the basic difference from the first generation is that here the pressure that is applied is controlled. So that is a difference. Now this goes to through a sleeve, so it won't go much beyond this. Come and pitch here and won't go much beyond it. So by which you can actually control. You can't apply too much force. So that is the basic idea of a pressure sensitive probe. The third generation probe is the computerized and automated periodontal probe. Now these are probes which is actually connected to a computer, and these are probes which can actually automatically detect your periodontal pocket. It can automatically detect the semi-dynamic junction, and thereby it can give a clinical attachment level. That CAL detection automatically is being generated, and it's available from the computer. That is the basic idea of a third generation probe, which is computerized and automated periodontal probe. So here the force is controlled, angulation is being controlled, and you have automated measurement, and all these data is available in a computer. Example are Florida probe, Toronto probe, interprobe. So these are different examples of computerized and automated periodontal probes. That is the third generation periodontal probes. Another example is a Photostimulable probe. Now, what are the parts of a third generation probe? It has a handpiece. It has a digital readout. It has got a foot switch. Only when you press the foot switch, it starts measurements. And it's got a computer interface. And there is a computer. Now, this is a Florida probe. That is the first type of Florida probe, which is actually marketed very long back on first generation. And you can see this probe. Look how it is so bulky this probe is. Okay. When you look at the your Williams probe, you see how small it is. This is so large, but it gives a lot of data. But it does not, because it's so large and so bulky, it does not fit in the NIDCR criteria. Okay, you can see a wire going like this, and it's attached to the computer. It's an old type of computer that is, and it gives whichever teeth is probing. According to that, the software it will give it will measure and give the reading. That is a Florida probe. Now the disadvantage is it lacks tactile sensitivity. The angulation is controlled, the force is controlled. So depending upon some areas may be more inflamed, some areas may be less inflamed. In more areas which is less inflamed, you may need a little more of force. In areas where it is more inflamed, you may need less amount of force. So these all cannot be controlled. So tactile sensitivity is not there. There is a fixed force setting for the entire mouth. As I said, with one, if you set it as 0.25 Newton, it will probe with 0.25 Newton in all the areas. It's bulky, as I showed you before. So these were some of the disadvantages of the third generation probe. Then came the fourth generation probe. Fourth generation in all these, the first, second, and third generation probe. It was only one dimension of the tooth was looked upon. But in the fourth and the fifth, fourth is actually two-dimensional probe, and the third one is the last one is a complete three-dimensional probe. Now here, the fourth generation, different dimensions are being measured here. It was introduced by Watt in 2000. And here you do sequential probing, and you get a three-dimensional measurement of the pocket. At different areas of the mouth, you probe differently, and this by means of the computer will absorb all these data and will give you a 3D measurement of the pocket. That is a basic idea. But fifth generation probe, the difference of this fifth generation probe to the fourth generation probe is that if you add an ultrasound to the third generation probe, that becomes the fifth generation probe. So it is more precise, and it does not, you can measure the attachment loss without actually penetrating the junction epithelium. That is one of the most, because of ultrasonic, based on ultrasonic waves, it detects the bottom of the pocket. And the probe that is available in the probe, I think the only probe that is available for fifth generation probe in the market is called as the US probe, or ultrasonographic probe. So these are the different generations of probe. The first generation is a manual probe. Second, pressure sensitive probe. Third one is computerized and automated periodontal probe. The fourth generation is a 3D probe. And here, the fifth generation is actually an ultrasonic probe, ultrasound with 3D. So these are the different generations of periodontal probe. So now we have come to the end of advanced clinical diagnosis, right? Where we have first discussed about gingival bleeding, then we discussed about gingival temperature, and finally we discussed about different periodontal probes. What are the, why there is probing disparity, what are the properties an ideal periodontal probe should have, and what are the different generations of periodontal probe. Now, this chapter means advanced diagnostic aids is a chapter which a lot of minor questions come, right? And probes is a definite short note for you. Perio Temp is a short note for you. Okay. Now we go to the second part of advanced diagnostic aid, which is known as advances in radiographic assessment. Right. Now, that what is the need? We have we diagnose periodontal disease by taking routinely by taking radiographs. We take a IUPA. You can take a bite beam, or you can take a OPG, a panoramic radiograph, and then you try to diagnose periodontal disease. But there are a lot of missing data in that, because one thing is because you have a radiopaque root, basically the bone levels in relation to the buccal or the lingual aspect of the root is being obscured. It isn't accurate. You can't accurately measure that in a radiograph. It gives only a very good idea of the interproximal bone levels. And the early bone loss is not detected. Okay, early bone loss, you need at least 30% of bone loss to occur in the alveolar crest so that it will be available. That change may be seen in the radiograph. That is why whenever we see some bone loss, and when you open up the flap, actually the bone loss will be much more than what you see in the radiograph there. So only that 30% bone loss should occur so that it is detected in the radiograph. So in the early stages of alveolar bone loss, you may not be able to get in the radiograph. So you have to overcome all these. And for overcoming all these and diagnosing accurately the radiographic changes associated with periodontal disease, you have to have certain advances. And that is what basically we're going to discuss in this chapter, advanced radiographic assessment. This part is a separate essay question for you. And these conventional radiographs are specific and they lack sensitivity. They are specific, but they lack sensitivity. No, but one thing is, there are certain data which cannot be obtained by, which only radiograph can provide. Okay, the only non-invasive way by which we can attain this data, certain data, is by radiographs only. Take for example, you want to know the length of the root. You are doing a root canal treatment and you want to know the length of the root. How will you measure that? You probably insert a file and then take a radiograph. Then proximity, is it converging? Is it diverging? If it's a converging root, probably during extraction it will come off easily. If it's a very divergent root, there is always a chance that the root will break, whether there is periapical lesion present or not. Otherwise, what you have to do to detect a periodontal lesion, you actually have to invade, you go into that area. It's invasive, you have to do a surgery there. Then what is the amount of alveolar bone that is remaining? What is lost, you don't know, but whatever is remaining, you can get by means of. So all these data, to obtain all this data by means of a non-invasive way, you have to take a radiograph. Root length, root proximity, the apical changes and radial changes, and what about the quantity of bone that is present after periodontal disease. But there are certain variability with conventional radiographs. What are the reasons? Because, if I take a radiograph and another person take a radiograph, that will be changes in the, you may not have a similar radiograph. One is variations in projection geometry. That is one thing. Second is contrast and density. That is, previously, nowadays we are using digital radiographs. Previously, when we use the conventional radiographs, the films, so there were problems associated with the film processing, the exposure time, the voltage, everything had an effect on the final radiographic picture that you obtained. And there is masking by the anatomical structures. So all these can result in the distortions in radiographs, and you may not be able to appreciate exactly what you want from that radiograph. You will not be able to get the correct anatomical projection from that radiograph. Now these are two radiographs of the same area, but different angulation. Now, according to this, just look at this interproximal area here. According to this, you may not find any bone loss only. There is no bone loss. Okay, this is perfect. But say the angulation was changed, and so almost it's going to that by the third. Till that area, the bone loss is there. So that is because of the disparity in the angulation. Another thing, look at this. The proximal area is completely full, but when the angulation is changed, the same tooth, look at this. So there should not be any elongation or shortening. It should be all taken in the same plane. That is a basic idea that we should have. When we take radiographs, you should always take in a reproducible plane with correct angulation. So how do you standardize radiographs? What is the need for standardization of radiographs? This is especially when you do a study, probably thesis, or you want to do research. Now you are looking at assessing bone levels, and then probably you are doing some sort of treatment. So suppose you are doing a bone grafting in relation to a defect. Then you want to know whether that bone graft has succeeded or not. So how do you evaluate? Probably you do a case today. So you take a pre-operative radiograph. Then immediately after that, you can take a radiograph. After your procedure, you can take another radiograph. Then you take a radiograph 3 months, 6 months, 9 months, 12 months, 18 months. And then from the baseline, you compare the bone levels periodically in these radiographs and find that the bone has formed there, or again the bone has formed. So for this, if you want to actually correctly measure the changes in these bone levels, you need to standardize radiographs. For standardization, one thing is, you have different techniques by which you can take a radiograph, especially IOPA. You can have a technique which is known as the bisecting angle technique, and then you have the long con paralleling technique. Bisecting angle technique, what you're doing is, now you place a film, and you place a film close to the tooth, and actually there will be an angle that is being formed, okay, between the film and the tooth, and straight within that, if you place the midway that is of the angle that is formed between the tooth and the film, you try to direct your X-rays exactly perpendicular to the bisecting line between these two angles, between the teeth and the film. That is the bisecting angle technique. So basically, whatever angle that is being formed between the film and the tooth, to that bisecting line, you direct your X-rays perpendicular to it. So that is the bisecting angle technique. But in parallel technique, what you do, you try to place the film exactly parallel to the long axis of the tooth and then direct your beam. So it will be more correct. But it's very difficult to take, you need specified instruments or accessories to take long cone paralleling technique. And radiographs has to be taken in a constant and reproducible plane. That's what I explained before. And for that, to standardize radiograph, you can use a film holder with a template containing impression material. I'll just show you. Now this is the paralleling technique. Now you have a film holder, okay, and this film holder is attached to this the X-ray tube, okay, and so it takes this film is placed parallel to the long axis, and then you take a radiograph, so you get a very good radiograph. Now this is where, especially in studies, what you do is, in areas where there's a paralleling technique only, this is a film holder, and this is where this area you place a silicone impression material. Okay, you ask the patient to bite. When you ask the patient to bite, that the occlusion will be imprinted within this. In the inside, you have the film. On the outside, this arm will project. This is where you have to attach the X-ray tube, and you take a radiograph. Now you keep this film holder with the impression paste. So probably after 3 months, the patient comes, you have to take another radiograph. This imprint here within made of this impression material, the silicone impression material, that will remain stable. So that will act as a guide for the patient to bite again in that correct position. So if you take a radiograph later, you will get same plane, same angulation, same orientation. So that is a basic idea of that. That's how you can get radiographs in reproducible planes. Now, what are the radiographic advances? One of the most common or most significant radiographic advances, digital radiography. Another thing that we say is subtraction radiography. Third one is CADIA, or computer-assisted densitometric image analysis. And the fourth one is, you can say, CBCT. You don't use CT not much in dentistry. Okay, so these, when you look at periodontal diagnosis, you can say 4. I've not included the 4th, but I will discuss that also. So one is digital radiography, second is subtraction radiography, and third is CADIA, or computer-assisted densitometric image analysis. Now, what is digital radiography? Now, you all know that. Now, previously, what we used to do, when we used to take a radiograph, you had to load a film within the camera, and then you had to expose the film, and then that film had to be processed, and then you get a picture or a photograph. Similarly, when you use the conventional radiography, you have a film, you place it in the area of interest, you expose the film by means of radiation, then you process that, you wash the film, you dry the film, process that, and then you will get that image, you will get that X-ray film. Okay? But nowadays, when you take a picture, how do you do it? Even with your mobile camera or with the digital camera, you just look, you just focus and just expose. You have a sensor. Light will pass through that camera and it will sensitize that sensor there. And this sensor will convert an image and it will show on your screen, whether it is a mobile screen or on a computer screen. So that same technology is used now. You place a sensor and then you pass radiation. The sensor automatically converts that image into a grayscale image and you can view in a computer. The advantages, these can be, one of the main problem with this, the conventional radiographs, the film radiograph is, you take a radiograph now, probably after 3 or 4 years, the patient comes again and when you look at the radiograph occurs blurred. You may not get, you not be able to store that image for a long period of time. That is one thing. You can't do anything once that you wash that film and its process. Now you can't manipulate anything with that. But look, the images in a digital format that can be stored. You have a hard disk. You can store it in a cloud. And you can get it after long periods of time. There's no distortion that can. And these images can be manipulated. How it can be similar to the editing that you can do associated with a photograph. You can brighten that. You can change the contrast. The density may be changed. You can make it more dense, lighter. Everything. Crop the image. Okay, you can magnify. So these images can be manipulated. Images can be corrected for over or under exposures. Very important aspect is when you look at digital radiography, the radiation is 1/2 or less than what is the radiation that is needed to take a conventional radiograph with a film. And all these, if we had to share a film with this IOPA with another dentist or another doctor and take an opinion, you will have to send it with the patient, or sometimes you will have to send it by post. But with digital radiography, you have that image, you can WhatsApp, you can email, okay, you can do a teleconferencing. Everything is possible nowadays with this digital technology. And also, it is more compatible with an electronic. Every dental clinic now has got a software. You don't write a case history in detail in paper and store all these x-rays. Now you have a software by which you enter all the details of the patient. And you take a radiograph and then you have a digital image which you can attach to that software in for a particular patient. So probably after a month or a year, the patient comes, you can retrieve the data. You can just type his name or probably a phone number or a registration number that's given in the clinic. You get all the data, you get all the images. Okay. And these are the different advantages. Now, when you look at digital radiography, you have, as I told you before, basically you have a sensor and the radiation, the X-ray waves will stimulate, act on the sensor, and that image is being converted into a grayscale and is shown on a screen. Okay, there are different types of sensors. The first type of sensor is the CCDs or CMOS. There were the whole generation of sensors. And now we have another type of sensor, that is the PSP or photostimulable phosphor plates. Well, how do you do in CCDs or CMOS? CCD is charge coupled device, CMOS is complementary metal oxide semiconductor. Now you place the sensor in the patient's mouth, and this sensor has got a link, has got a wire, and that is attached to your computer. On exposure, the image appears on the screen. But here in PSPs, you have very thin plates. It's similar to your X-ray, small X-ray film, a different dimension. It's flexible also. What you do is similar to how you take a conventional radiograph with the film, you place it. You place the PSP, you place the plate within the patient's mouth and expose. Then immediately it doesn't have a wire, it is not connected to the computer. And this stimulated or exposed plate, you place it within a scanner. And this scans the plate and you get an image with it. So you don't get it in CMOs or CCDs, you have The sensor is linked with the wire to the computer, but it is not linked here. The advantage is here it's very thin and it's more patient friendly. So PSP, when interacting with X-rays, PSP stores energy, and energy is released on stimulation of light of appropriate wavelength. So you actually expose plates are scanned. As I told you, you take the plate, you expose the plate in the patient's mouth, and then it's being scanned using laser beam, and then the image appears on the computer screen. But this is more precise. What are the advantages of digital radiographs? We have already discussed that. Speed. You take a radiograph, immediately you get it on the computer. Conventional radiograph, you take a radiograph, you have to do all processing, wait for it to dry, then you get the image. A lot of time that's taken. X-ray exposure. Exposure is very high. The dosage of radiation is half to 1/3 when you do with digital radiograph. As I told you, you can manipulate the images, you can shorten it, elongate it, you can change the density, you can change the color, the intensity. You can actually make measurements. You have digital tools by which linear, angular, intensity measurements may be done. You can improve a patient education. Just imagine a small radiograph, IOPA, and explain it to the patient. Patient may not be able to see the radiograph also, but you just show that image within the computer screen or any laptop and explain to the patient. How the patient will be able to appreciate that. So improve patient education. And as I told you, we can easily store it. You hardly, it doesn't get distorted itself. You can store in a CD. You can use a hard disk, or you can store in a cloud, and you can transfer it for any event, for share it with anyone. And it's compatible with the electronic patient record management software. So these are the advantages of digital radiographs. Now we come, so we have discussed the first part of advances in radiographic diagnosis. That is, first is digital radiographs. Now, mind you, this digital radiograph is a favorite short note. It's a common short note. It's a common short note. You have to know about it. You have to know about what are the advantages of this, what are the limitations of these old conventional radiographs, the advantages of this digital radiographs over conventional radiographs, and what are the different types of sensors that are involved. These are things that you have to know about it. Now is subtraction radiography. Now, here you are taking serial radiographs and converting into digital images. What you do is you take a radiograph. Suppose you are doing, you want to do a research, or you are evaluating one area. Let's look at 4/6 area. Okay, you take a radiograph 4/6 before your treatment. After your treatment, immediately on the day of your treatment, 3 months, 6 months, 9 months, 18 months after your treatment. So all these are converted into, you take serial data, all these are radio, and all these radiographs are being put into one software. Okay, so all these are superimposed, and these images are superimposed, and the resultant composite is viewed on a video screen. And you may appreciate the changes in density or volume of the bone. Okay, and bone gain will be lighter areas, bone loss will be darker areas, radiolucent. So basically, now suppose you are doing bone grafting. Suppose you are not doing a bone grafting, you just do a flap surgery in relation to 4/6 area, and you want to know over a period of time what changes are occurring to the bone in that area. So what you do? So you take the first radiograph before your procedure. As I told you, then you take radiographs at different intervals of time. And here you put you superimpose all these radiographs into one area. And then you look for changes, whether from the baseline bone is formed or from the baseline bone has come down. Okay, if bone is formed, it may appear as lighter areas. bone is come down, it may appear as darker areas. So that is known as subtraction radiography. You subtract all unchanged things so that you can have only the changes will be seen. So that is the basic idea in subtraction radiography. But needs standardized. You take radiographs in different angulations and different planes. It doesn't work here. All these has to be standardized. This is you take in different areas, and it may either be bone loss or bone gain. That is the basic idea. And a lot of studies shows that it has got high correlation with scaling and root planing and clinical attachment loss following therapy. So bone gain can be seen, but slight osseous changes can be detected. Early osseous changes can be detected by means of subtraction radiography, while some major changes has to take place so that it is appreciable in a regular radiograph. That is the basic idea. You don't do it regularly in your clinical practice, subtraction radiography. It is done only for research purposes. Disadvantages, you have to actually take radiographs in very reproducible, correct angulation, correct paralleling technique. Next one is CADIA, or computer assisted densitometric image analysis. Now this is something that you probably have to by heart. Now here what happens is, a video camera actually measures the light that it passing through. You allow light to pass through a radiograph, and you record that with a video camera. And these signals on the camera are converted into grayscales. And this is interfaced with an image processing computer. And all the storage and mathematical manipulation is being done by this computer. And then you get the minute changes in bone loss. So that is basically what you do in CADIA, computer assisted densitometry. Allow light to pass through a radiograph, and then it is captured in a video screen, and the video actually is converted into grayscale, and then it's being manipulated and measured by means of software. So this, and this is supposed to be this procedure has better sensitivity and reproducibility than digital subtraction radiography. That is CADIA. Next, the very common diagnostic method in the industry today is a very significant diagnostic method in the industry today is the CBCT, cone beam computer tomography. But you can three-dimensionally. The idea is, in CBCT you get a three-dimensional picture. In all other radiographs you probably get a two-dimensional picture. Here you get a three-dimensional picture. So you can actually, if it's a 3-wall defect, 2-wall defect, angular defects, bony, so whatever bony architecture can be easily assessed by means of this CBCT. But do we use in routine periodontal diagnosis? No. Now this is not routinely used in periodontal diagnosis. You use, one of the reasons is, one is the exposure to the patient is very high. So only in cases that you actually very much it is indicated, you prescribe a CBCT. Otherwise, you don't prescribe a CBCT. You go for your conventional radiographs only. But this is very useful in case of you're doing implants. You can plan implant treatment beautifully with this. You can know the different bone levels. You can know what are the width, the length of bone that is available, the density that is available, what are the anatomic structures that are coming close. All these things can be clearly evaluated, and you can plan your surgery in implants. So these are the different advanced diagnostic aids. One is digital radiography, second is digital subtraction radiography, third is computer assisted densitometric image analysis, and now cone beam computer tomography. So we have come to completed half of advanced diagnostic aids. That is, we have discussed about the advanced clinical diagnostic aids, and then advanced radiographic diagnostic aids. Now, two aspects of advanced diagnostic aids are still left. One is the advances in microbiologic diagnosis and advances in characterizing the host response. Now, these two we'll do in a separate session. Thank you. Thank you all. Thank you all for listening. Thank you.